Good afternoon. More than a year into this global pandemic, and we now find ourselves at a crossroads. Over half of American adults have received at least one dose of the vaccine, and children have started to return to classrooms. And gathering between those vaccinated are now taking place. The work of scientists and health researchers has been nothing short of amazing. But as I look ahead, I must admit that I see some of our biggest challenges remaining. That is what brings us to today's incredibly important conversation. A look back, a path forward, COVID-19. Good afternoon, everyone. I'm Michelle Williams, Dean of the Faculty here at the Harvard T.H. Chan School of Public Health. And it's my great pleasure to welcome you to our town hall event with Dr. Anthony Fauci and with support from Google. Right now, I'm only cautiously optimistic. Why? Because we're in a race against fast spreading variants and vaccine hesitancy. Because we're grappling with the politicization of vaccines, and because we are running up against misinformation and persistent societal inequalities. The Kaiser Family Foundation recently estimated that the United States will reach a tipping point in vaccine enthusiasm within a week, meaning herd immunity is not yet within our reach. At the same time, global coronavirus cases are surging. India and Brazil's healthcare systems are on the brink of collapse, and widespread vaccine access remains a very distant hope in some parts of the world. We must do better. You know, back in March 2020, Atlantic writer Ed Young wrote, "Aspects of America's identity may need rethinking after COVID-19. He went on to say that many of our country's values have worked against us during this pandemic. Thus, ending this pandemic is going to require discipline at every level, from every sector, from every one of us. And just how well we do will be a reflection of just how purposeful and powerful we all are collectively." Let's take a look back at what a profound year it's been.
Now to growing concerns about the deadly coronavirus officially hitting the U.S.
It's the most daunting virus that we've contended with in half a century.
Breaking news tonight, the coronavirus outbreak declared a global pandemic.
Was having terrible economic consequences, terrible consequences on employment.
Converting operating rooms into ICUs, converting the PACUs into ICUs, converting regular floors into ICUs.
You know, sometimes I'm grieving for my husband and then I realize my mom's gone, you know, and then I'm grieving for my mom. And so the two people that would have been so supportive, that the other one gone.
It's estimated about 40% of our workforce is still going to work, and many of these are low-wage workers and disproportionately people of color.
Black Lives Matter! Social justice protests collide with the pandemic. By August, more of the COVID map turns red.
Tonight, the confirmed global death toll from COVID just reached 1 million.
The first vaccinations in New York.
We have got to come together as a global community to figure out how we're going to contain the virus in every country at scale.
At least 15 states now no longer have restrictions on most or all of their businesses.
I'm going to lose the script, and I'm going to reflect on the recurring feeling I have of impending doom.
The hard part's ahead of us. We've got to outrun the spread of these variants.
That's our look back. Now, please join me in welcoming today's moderator, Sam Baker, health editor of Axios. Sam, I'll turn it over to you.
Thank you so much, Dean Williams. It's great to be with you, and it's an honor to join all of you today at the Harvard T.H. Chan School of Public Health for a town hall conversation with support, as the Dean mentioned, from Google Health and YouTube, featuring Dr. Anthony Fauci. As we saw in that video, and as we have all experienced firsthand, the past year has been a year of unimaginable tragedy, and at the same time, unprecedented scientific progress. And so what we're going to talk about today is exactly where that moment has left us, where we are right now, and the path going forward. We will also be joined in that conversation by Karen DeSalvo, the Chief Health Officer at Google Health, Garth Graham, the Global Head of Healthcare and Public Health at YouTube, Harvard Epidemiology Professor Michael Mina, and Mary Bassett, the Director of the FXB Center for Health and Human Rights. We are also joined by students from all over who will have the opportunity to ask questions during this program, but we begin first of all with Dr. Fauci. Dr. Fauci, thank you so much and welcome.
Thank you. It's good to be with you.
So just to sort of recap where we are, half of American adults have gotten at least one shot, 1 billion shots worldwide. We know those are fantastic numbers. Those are great numbers, but we also know it only gets harder from here. Cases aren't really going down in the US. They're certainly not going down worldwide. And so my first question to you is, do you think herd immunity, whatever the specific number may be, because I know that's been sort of a moving target, but getting there, wherever there is that realistic at this point?
You know, I do think it is, but I tend to want to make sure people don't get fixated on this mystical number, which we don't know what it is, of herd immunity, and focus much more on the fact that we are in, as I think was alluded to in the introduction to this piece, that we are really in somewhat of a metaphorical race between the implementation of vaccinations, which we're doing very well. The numbers you gave are obviously correct, but they're also very encouraging. And the fact that even in the context of our capability and our resources of being able to vaccinate people, we are still in a very precarious place with regard to viral dynamics. We now have a 7-day average, about 60,000 new cases per day, which when you look at the danger of a possible surge, particularly given the fact that the dominant variant right now, the B117, clearly has a greater capability of spreading, we really need to get people vaccinated as quickly and as expeditiously as we can. And if we can get 3 million people a day vaccinated, literally within a period of a few weeks, we're going to start to see a turning around of the dynamics, not down to no infections. I mean, if you're waiting for classic measles-like herd immunity, that's going to be a while before we get there. But that doesn't mean we're not going to have a significant diminution in the number of infections per day and a significant diminution in all the other parameters, namely hospitalizations and deaths, before we actually reach herd immunity. So whatever that number turns out to be, which is a combination of the protection from the vaccine, as well as the protection of those who've been infected, have recovered, and now have essentially immunity related to infection. The reason why I want to shy away from a magical number is because several aspects of that are really moving targets. For example, we don't know what the durability of the infection-induced immunity is. We don't know if someone who got infected last winter or in the early part of 2020 is going to be safe from the standpoint of being protected now. So why don't we put that aside and say, we need to put a full court press on getting as many people vaccinated as we can. If you look at the curve in Israel, it's a really interesting curve. where the infections were going up, but the number of vaccines were going up. And then at around 60% of the population being vaccinated, the lines crossed. The infections went way down and the vaccines keep going up. So we just need to strive for as many people as possible to get vaccinated as quickly as we possibly can.
The CDC said, I believe either yesterday or this morning, that about 5 million people, I think, or about 8% of people who've gotten at least one shot did not go on to get the second shot. Can you sort of contextualize that number for us? Is that encouraging that it's not higher? I mean, obviously you'd like it to everybody to get the second shot, but that's...
Yeah, well, Sam, I know, I was gonna say the same thing that you said. I'd like it to be 0%. 8% is a number that when you contrast and compare it with other situations in which you require more than one shot, where you require a prime and a boost, such as the zoster vaccines or the hepatitis B vaccines, by human nature alone, there's always a certain percentage of people who for one reason or other don't come back for the second shot. In fact, the number for zoster is higher than the current number for SARS-CoV-2. So I'd like to see that number diminish. I certainly don't want to see that percent go up. And that's the reason why we've got to continue to outreach to people to convince them of why it's so important for themselves, for their family, and for the community to complete the full component of the vaccines.
Looking at the rest of the world, obviously, cases are at an all-time high right now. We see India driving so much of that, really a terrible situation there with running out of oxygen, hospitals are full. And the United States is still sitting on however many doses of the AstraZeneca vaccine. Why not send those to India?
Yeah, I know you heard over the weekend, Jake Sullivan, our national security advisor, talk about all of the things that we're immediately going to be doing vis-a-vis oxygen, remdesivir, other drugs, PPE, and all the kinds of things that we can move immediately on in his discussion with the national security advisor of India. I think we can safely say that the issue of doses of vaccine, particularly the AZ vaccine, are certainly under active discussion. And I would say safely that everything is on the table right now for discussion.
Okay. I wanted to also ask you about masks. We've seen sort of a drumbeat here that maybe states and cities should relax rules if they are still requiring mask wearing outside, since some of the scientific evidence doesn't necessarily suggest that the risk of outdoor transmission is very high. At the same time, there are plenty of people not wearing their masks inside, as there consistently have been, which the science very much suggests that they could. Can you sort of tell us what the future of these guidelines is, when we're likely to get some new guidance, if it's going to change?
Yes, I can again safely say that really, really soon, we're going to be seeing some guidelines that are going to be coming out from the CDC about the wearing of masks in vaccinated versus unvaccinated individuals. As you know, the CDC is a science-based organization, and they make their recommendations based on the data that they can accumulate or modeling or just, common sense public health measures. And obviously everyone is asking the question that you said quite correctly, Sam, that the risk of infection outside is really minimum. If you're vaccinated and you're outside, it's even less. So what we're going to be doing through the CDC is soon, very soon, clarifying the situation vis-a-vis masks in vaccinated versus unvaccinated people. So stay tuned, it's coming.
And we have a question on that front, the difference between indoor and outdoor risk, from Professor Joe Allen, the director of the Healthy Buildings Program.
My question is about moving forward. So if we know time indoors is the biggest risk factor, aerosols are driving transmission, and this is important for other diseases like influenza, why, when I look at the funding for your agency and search for things like indoor air, ventilation, filtration, aerosols, I only find a handful of studies funded, and most are about asthma? So has this pandemic changed your thinking on bringing the field of building science more into the fold with your agency?
Yes, but we also do that with other agencies in addition to our own. But your point is very well taken. I mean, obviously, there are so many aspects of the way we address respiratory-borne illnesses, and the issue of aerosol has always been a very important component. I think the thing that has been really an eye-opener for us with regard, for the entire field, not just my institute, with regard to SARS-CoV-2, is that most experience, in fact, virtually all the experience with respiratory-borne illnesses, is that although there's a minor component of transmissibility when people are not symptomatic, namely when they're just speaking or singing or what have you, has been relatively minor, and most of the transmissions have been driven by symptomatic people. That's absolutely not the case with SARS-CoV-2, where you have 50 to 60% of all transmissions are transmitted by people who are infected, who either have not yet gotten symptoms, namely are pre-symptomatic, or have never going to get symptoms, which means that just speaking or singing is going to be transmitting. And to me, that's really a good example of why we need to investigate that a lot more thoroughly, not only for now, but for future pandemics.
So I wanted to ask, you were mentioning there the CDC is a science-based agency, and all of these recommendations are driven by science. Obviously, none of us have ever done this before, a global pandemic. I wanted to ask you sort of about public health communication and risk communication. Obviously, science and our scientific understanding of this virus has changed. There has to be some way to account for that. There have been, seems like, some difficult decisions about how to communicate, for example, the risk of blood clots from the Johnson & Johnson vaccine. I wonder how well, again, with the context that no one's ever done this before, how well do you feel that the public health apparatus in the US has done on sort of communicating that risk to the public?
Yeah.
And what have you learned about how to do it better?
Well, I mean, there are things that have been confirmed by our experience here that we knew back with other diseases, including the extensive experience that we have and continue to have with HIV/AIDS. And that is the issue, which is really fascinating because, I mean, I've particularly been interested in this because of all of the experience that we've had with HIV/AIDS is the issue of relative risk and new risk. So it's extraordinary human nature when you give a new risk to an individual, even though that risk is far less than a risk that they accept every single day for something, but they're used to it, they get much more concerned about the new risk because they don't put it into the context of the relative risk, namely compared to other risks you have. And I think that's one of the things that's not easy to communicate because the general public doesn't usually think about it like that. But it relates to what I think you're getting to, Sam. For example, going out without a mask in the public when you know that the virus is very unlikely to transmit outside. I mean, we know that from experience. Yet, if you go outside without a mask, what is the risk? I mean, it's a risk that, from the standpoint of our own personal history, this is the first time we've been dealing with SARS-CoV-2. But the risk of something bad happening to you going out have nothing to do with SARS compared to the risk of getting infected without a mask being on is really quite small. And I think that's the thing that we need to do better in communicating to individuals is that there is a really relatively low risk. And we need to make policies based on that. And what kind of a risk is the public willing to accept when it's in a new area that they haven't had experience with?
Okay. Dr. Fauci, let me bring in some of our other distinguished guests here. They are Karen DeSalvo from Google Health and Garth Graham from YouTube, Mary Bassett and Michael Mina from Harvard Chan. Thank you all for taking the time to be part of this conversation today. I want to start off with a quote from Jamie Dimon, the CEO of JP Morgan Chase, his most recent letter to shareholders, where he said he feels good about the direction of the American economy, but that the virus and the pandemic are still the greatest threats he foresees. He said specifically that variants, quote, could obviously reverse a booming economy, damage the equity markets, and reduce interest rates as there is a rush to safety. Karen, I want to start with you. There's an awful lot riding on public health here, not just lives and livelihoods, but the global economy. Can the public health system that we have pull this off?
Well, you know, Sam, the public health system has done an extraordinary job of pulling off a response to the pandemic. So let's just begin there, especially given the state that it was in as the pandemic began. I think most people don't realize that the public health infrastructure in the US has been underfunded for decades now, meaning that as it moved into this 21st century challenge of the COVID pandemic, it was often working with 20th century tools. I think a lot of folks saw the headlines of fax machines being deployed to share test results or to make sure that cases were getting reported. And, you know, I know the public health infrastructure found ways to work around that, though I think it's exciting to think about what's the next chapter of this work, which is to make sure that we have a 21st century public health system in the US with the tools at its disposal to very rapidly respond, but also to do more in forecasting what might be coming down the pike. But we'll also share this, Sam, as extraordinary as the public health infrastructure has been in doing its work to respond to the pandemic. We should all remember that public health is what we do together as a society to create the conditions in which everyone can be healthy. And we have seen wonderful examples in this pandemic of the public and private sector coming together to make a difference and to get information to the public, to advance science, to advance therapeutics in the field. And so let's not forget that everyone has a part to play, whether it's the medical system, the scientific infrastructure, the private sector. The concrete example for us here at Google is we see ourselves as a way to amplify the important messages of people like Tony Fauci or the CDC or the FDA to make sure that their scientific-based messages are getting out to the general public. So it's going to take all of us, not only in this pandemic, but also going forward to make sure public health has the tools and the strength to continue to protect the public.
Sam, let me jump into one of the things Karen just said. You know, this idea of how you communicate information is so important, particularly to various audiences, making sure the information is engaging so that it appeals and people get information in a way that they're used to getting information. So for instance, on YouTube, you know, about 2 billion people come to the platform every month. If you think about it, the world only has 7 billion or so people. So our ability to reach communities across the globe is particularly important. But our ability to do what Karen just said in terms of amplification of messages for specific communities and reach them. For instance, today we launched a campaign really aimed at 18 to 34-year-olds, encourage them to get vaccinated, encouraging them to getting back to the things that they love, knowing that they utilize the platform. You know, those kinds of activities and tools, I think, are a good way for us to work together hand in hand with public health at both the state, local and federal level. So just adding to Karen's point about amplification of communications, making sure it's engaging and that it's reaching people where they are.
Dr. Fauci, anything you'd want to add there? You know, this is also a global challenge, obviously.
Yeah, I think Karen and Garth said it very, very well. I mean, that's exactly what we need to do, obviously.
I'd like to spend a couple minutes here on an important part of both the pandemic and sort of what the pandemic has exposed about the healthcare system and to some extent American society overall, and that's equity. And Mary, maybe let's start with you here, starting from where we are, from now, you know, with the limitations that we already have. What would true equity look like going forward?
Thanks, Sam. I agree with you that the pandemic has really pulled the curtain back on the inequities both within countries and between countries. And I'll say a few words about within the United States, but I do want to highlight that the biggest inequities are between the wealthy countries and the rest of the world. And we are witnessing that on display right now in India. But we're thinking that, Africa, we hardly even know what's going on. And what equity means is that everybody should have an equal access to protection from risk. And that's not only the risk related to getting vaccinated or not, it's the risk related to your risk of exposure. And in that, we know that people's jobs, where people live, their ability to take sick leave, their ability to take time off to go get vaccinated, to make their schedules flexible, all of those are related to inequities, which have meant that people of color in the United States have been more likely to get infected, more likely to be hospitalized, and more likely to die of COVID-19. And that's true today, as it has been from the very early months of this pandemic. So equity would mean that all of us have the opportunity to modify our risk so that we face, an equal chance of protection and an equal risk of exposure. We're not there. We're not there. But it's within our reach, right? These are things that we can change. And Karen talked about the very social nature of epidemics, and they reflect these broader social risks, not only access to commodities or personal behavior.
Sam, Mary's 100% correct, maybe 1,000% correct. Would just want to put a message out there that often following crises, whether they're public health crises like this or natural disasters, we see inequities because the curtain is pulled back and it's on the front page, it's in the headlines in the news. What I hope is that as we go forward out of this pandemic, that we don't turn our attention to something else and forget what we have learned. I want everyone to internalize, for whatever sector they're in, whatever their role is every day, to think about the kinds of things that Mary's saying, that inequities take many shapes and forms, that it's all of our responsibility to make a difference, and that we have to make sure we have the right data, the right information to act on that so that we can make sure that we're making progress to make improvements and not just have it have been something that popped up during the pandemic and we then move on to the next crisis at hand. Having experienced that in Katrina, when it was really clear that our community had a number of inequities, we had to fight hard to make sure that we were thinking about inequities as we were rebuilding the system. But I also know that it's easy for that to then fall to the back burner if you're not really intentional about paying attention to it and building it into all of your efforts.
Now, Sam, one other additional thing that I've thought about a lot, and what Mary and Karen said is absolutely true. There's the corporate memory of inequities, of immediate things that you could do. But the thing that gets forgotten even more is the long range inequities, the social determinants of health that have taken years and decades, if not centuries, to get to the point of having the underlying comorbidities that brown and black people have that have nothing to do with race. It has to do with the situation they find themselves in. The poor diets from birth, the lack of access of health care. That's the reason why you get the hypertension and the diabetes and the obesity. That's going to take decades to unravel and to correct. So that's the thing that I hope that we don't forget, that we can't just say, well, we're going to be really good for a year. It almost has to turn around. What we have to admit, which is true, is the deep, profound racism that has brought us to this point over so many years. That's the thing we really got to get that spotlight on, and don't let that spotlight get dim when we're 2 years out from the outbreak. That's going to be difficult, but we have to do it.
If I may, Tony is highlighting this issue that health is more than healthcare. And Tony, I think a lot of public health hearts in the US and around the world just swelled hearing you speak so articulately about the social determinants of health. So thank you. It is absolutely the way we're going to have to work going forward.
And it's good public health is the other thing that we have to say, that if we don't tackle these issues, then an even worse virus may be waiting, and these vulnerabilities will remain. And I think there are things we can do that are not so long-term as figuring out how to undo white supremacy, which has so imbued the United States. There's, paid sick leave, there's access to health care, there's ensuring that people have access to affordable housing. Many of these issues are actually being addressed as we begin to address as part of our response to the pandemic. So I want to echo what Karen said. It is so important to have you saying these words, Dr. Fauci, and other leading figures in the current administration.
One of the things, to Sam, I'll add to that is that, and Mary and Karen and Dr. Fauci has done, so there's so much leadership they've provided for this, not just in this instance, but from many years before. One of the things we can't forget is the power in communities. A lot of times communities are looking for the opportunities, not necessarily for us to give gifts or a handout, but just the opportunity to be able to live their best lives. And I think part of the opportunity here for us to look at is, again, how do we empower communities at the local level? And we've seen a lot of that during this pandemic. We've seen a lot of Black doctors, Black healthcare leaders, brown healthcare leaders, folks from the Native American community, folks from all communities take on a leadership role and really move forward the needle in local communities. I think acknowledging the ability and capabilities to do that, and just this concept that there's a lot of power in local communities for us to harness.
I want to continue this conversation, but I want to bring in a student question here. We have a question from Koki Ajiri.
Thank you so much, Sam. And hello, Dr. Fauci. During a 2019 simulation, a Chinese respiratory virus infected 110 million Americans, taking the lives of 500,000. What didn't they apply it to a response?
Yeah, you're asking a really good question. Pandemic preparedness, we were ranked by Hopkins School of Public Health as being the best prepared for a pandemic of any country in the world. And you've seen what happened, where we now have 570,000 deaths and several million infections, 31 million infections at the last count. So the issue is there's a difference between preparedness and response. And I believe that even though we were preparing in a way that was sort of for the last outbreak and not for the outbreak that came, that we need to really take this experience and a lot of things, some of the things that Karen started off by saying, that our own public health infrastructure locally was let to attrit over a period of decades. So when we had to do things, simple things, like identification, isolation, and contact tracing, that was really not done very well at all. We didn't have the right tests. We didn't have the right infrastructure. We were trying to contact people by phone instead of doing it physically, and it just didn't work. So even though you have a plan that looks like it's good, you really have to be able to respond in a way. One of the generals in our current armed forces, who was a wise person, told me something when we were in one of our meetings. He said, you have to plan for a battle, for absolutely certain. But when the bullets start flying and the fog of war comes in, the plan, although it helped you, is not what you actually follow. So you've really got to be flexible enough to be able to respond, because together with preparedness comes response. And that's where the lesion was, how we responded.
Michael, I want to bring you in here as well. You have been advocating pretty strongly for a pretty significant increase in rapid at-home testing and making the important point, I think, that testing is still very much part of the solution here. We are starting to see more of that, more rapid tests, more at-home tests. do you feel like we're in the right place, getting to the right place? Has the game been changed testing wise? How do you sort of rate the progress that we've made there?
Yeah, well, I would say we are finally starting to see these tests at this point now start to make their way into people's homes. But as we just heard, we need to, in the midst of a pandemic like this, we have to be able to adapt. And to this point, still, we have barely seen any adaptation in our regulatory pathways to ensure that there is accessible and equitable testing that is giving results in a time frame that's actually commensurate with what's needed for this pandemic. And I think we're only now scratching the surface of what we should have seen last summer. We can't reverse time, but it is worth really putting out there that had we, all we had to do to stop the surges of the winter and fall was ensure that for every 100 infections, that there were 99 new infections that arose from those. That's what we had to do. And had we done that, we would have prevented those massive outbreaks and hundreds of thousands of lives might have been saved. We didn't develop the framework to get the regulatory framework to get the type of testing we needed out. And people say, well, it's just tests. Tests aren't going to be, the same as vaccines, but tests are the only way we know where the virus is when it's around us. And it's absolutely essential. And so it was essential, last fall, we didn't do it in an appropriate way. But moving forward with new variants, we absolutely need to keep our eye on the ball with making sure we have eyes on this virus. The variants and just, the vaccines are amazingly important, but they are not the end all be all to this pandemic. As we've been hearing, we need to be able to keep monitoring, keep ourselves aware of if we're infectious. The best thing you can do is empower people to know that they're infectious and give them the means to be able to know that and to identify themselves and stay home. And I think we're on our way there. I would like to see regulations catch up to sort of and respond to this pandemic in a more appropriate way.
So we have obviously seen a pretty significant decline in overall testing. And there are exceptions to what I'm about to say, pockets where this isn't true, but sort of overall access to relatively fast PCR testing that's cheap or free is not that scarce in the US. Testing capacity has increased so much. So I wonder, how do you convince people that this is something they still need to do? Would people test themselves if we just sent them one for free in the mail?
Well, that's actually, there's an experiment going on right now, run through the NIH and CDC to evaluate just that question. Are people interested and willing to test themselves on a frequent basis 3 times a week if given tests for free, and really trying to remove as many possible barriers? We have a study going on right now with Citibank, where the employees at Citibank are using their tests 3 times a week at home. What we're finding is if you make these tests as accessible as your toothbrush, people will test themselves. People want to know it's 30 seconds out of your day. And that's a big difference. The moment you even add 20-minute drive to have to get a test at your local CVS or Walgreens, that is a barrier people generally aren't willing to hurdle over, especially when cases are low. But if the tests are there in your bathroom, next to your kitchen sink, wherever they might be, people will use them. And I think that is one of the most important things about making these inexpensive rapid tests available to people on their terms.
Sam, just a contextual point about what Michael's sharing and a reminder to what Tony shared earlier, which is that testing is a part of a broader system of contact tracing and has to be thought about with respect to what will people do with the information? How does it get to public health authorities so they can act on it appropriately? And then also there are considerations about if people know their status, what is the impact for them on their livelihood? Because I think for some folks, it means they can't go to work that day, which means they may not be able to make rent that month. So as we're advancing the technology around testing, it's just a good reminder that in the public health infrastructure, we have to think about it in context and about how it might drive inequities or improve equity overall. And we've seen a number of challenges in the pandemic of uptake of tools like testing because of how it might affect individuals' livelihood, but also the public health infrastructure hasn't always been able to do the intake of the various positive tests. So not saying not to do it, I'm just saying we have to remember that the test results go someplace and have an effect beyond just the person making a decision about whether they'll isolate.
Dr. Fauci, with testing sort of especially early on, we see it now with vaccines, there's always this sort of question of access versus hesitancy. You know, do people just not want to do it, or has it not been made easy enough or accessible enough for people to do these important aspects of our public health response? I wonder how both in the testing capacity and in the vaccine capacity, you sort of know which is which, or how much of our problem is which or which.
You know, you bring up a very critical point, Sam, because when you talk about hesitancy, excuse me, for anything, be it for vaccines or wanting to get tested, there are going to be a hardcore group of people who don't really want to be told that they need to do something regardless of what it is. But there is another equally, if not greater, proportion of people who, if you extend yourself and give them greater access to it, the way Michael was saying about having something that is like, you know, getting up in the morning and getting your teeth brushed. You can go into a pharmacy and for very little, not get one test, but get a whole pack of tests so that you could test yourself as often as you want. That would make it much more easy, and you get a lot more people who'd want to do that. It's the same thing that we're facing now as we're narrowing down on a smaller cohort of people who we want to vaccinate, because we've already vaccinated, as you said, greater than 50% of the adults have already received at least one dose. As you get that cohort smaller and smaller, you've got to reach out more to get more easy access. And that's the reason why we've established the COVID community core, to get trusted messengers out there, to get people to get vaccinated, getting the community vaccine centers set up in areas of not very good access, such as minority areas, getting the federally qualified health centers, getting the mobile units, getting pharmacies up in areas that are generally difficult to access, getting people who are vaccinators out there in droves so you don't have that as a stumbling block. So the answer to your question is, you can get people to either get vaccinated or do testing if you make it really, really easy for them to do that. You may not get the hardcore that don't want anything to do with it, but you're going to get a lot of people who would do it if you actually made it more convenient.
And I would add to that, Sam, you know, hesitancy and empowerment kind of go hand in hand. So how do you empower communities with information so they can make the right decision for their families and for themselves? And you think about, again, this concept I mentioned before about empowering communities and how you reach people. Dr. Bassett did this piece for us with the hip hop person Dapper Dan. And it was so creative because it got deep into those folks who are, on the corner looking at their phones. They're trying to figure out what's going on. Dr. Fauci did a similar thing with us with the rapper Fat Joe. And I mean, those are communities that I understand and people who I relate to. And so when they get the information in this way, they get empowered. They get to ask the questions. Dr. Fauci, I remember Fat Joe asked you who your favorite rapper was. And though you and I may disagree on that answer, the truth is just answering that in the way you did allowed people to relate to you, and it made it an empowering, a community statement. And that's the way we have to think through about how we reach communities, reach them in person, but we will reach them at scale. We want to engage them in the right way. And so I think of hesitancy, but I also think of community empowerment with information as a vital tool as well.
Yeah, who knew I was going to be an honorary rapper, Garth, right?
Now we all want to know what your answer was.
You have to watch a video.
I think, though, that it's really important that we drill down on access, which is what, Tony, you've been talking about, that if we can get everybody who's either watchful waiting or willing or to get vaccinated, we'll have gone a long way. I don't want to quote any magic numbers, but I think it's something like 10% of the Black population in the U.S., according to the Kaiser Family Foundation. So there may be other polls that say that they'll never, ever get the vaccine. 15% of whites. In that group, of course, it's the Republican men and evangelists who are up towards 30%. But in aggregate, we have 80% of the U.S. population has either been vaccinated, is planning to, or is watching and waiting to decide to get vaccinated. And for them, it has to be as easy as possible. If somebody can't take a day off work to go get vaccinated, that's a problem. If it's really hard to schedule an appointment, if it's far from where you live, that's a problem. And it's really exciting to hear that all of those are being lined up as barriers that can be overcome. So that, I think, more than, sort of hearkening back to historical misdeeds, let's focus on access.
That also, part of, so much of this is about communication. And so I want to throw open to everyone what I was asking Dr. Fauci about before, which is how to sort of stay true to the top line truth that all of these vaccines are highly effective. All of them have been proven safe through their clinical trials and in real world settings, while also doing the responsible thing with, for example, some of the safety signals that we've gotten from the Johnson & Johnson vaccine. Mary, I'm curious for your perspective on how well that's been handled, what you feel. Can you just sort of walk us through, I guess, the challenge of doing those two things at once, especially in this crazy information ecosystem that we live in now?
Sure. As everybody knows, there was a pause in the Johnson & Johnson vaccine for about 2 weeks while a decision was made on this very rare clotting problem that's been identified in women, more likely younger women. And the numbers were always such that I think everybody expected that the vaccination would continue as it has. The single digits out of 1 million was not going to be a case for not using this vaccine to protect people against COVID. So 2 weeks was longer than I thought the pause would be. But I do have to say that everybody in leadership at the national level has had a steep hill to climb in terms of regaining public confidence in the science. And everybody needs to feel that these issues are acknowledged, that there's transparency, that it's been carefully examined. I really do only worry that this is a workhorse vaccine along with the AstraZeneca. And I hope that people remember this sort of subtle point that there's a risk, but it's a very rare risk, because as Dr. Fauci began at the beginning, people want there to be no risk. And there is no such thing. We have to turn to our communications people to help with that. So 2 weeks was longer than I thought it would be, but I think that it left everybody confident that it had been carefully examined and that it was an appropriate decision to return with a labeled warning. Dr. Fauci, what do you think?
No, I agree. But one of the things on the other side of the coin, Mary, and you did allude to it just a moment ago, is that, that was based on 8 million people who got the vaccine. There are 141 million people have received at least one dose. So that means that 123 million people received either the Pfizer or the Moderna mRNA. And the same survey system that picked up that exceedingly rare adverse event with J&J is monitoring the Moderna and the Pfizer, and yet there has been zero red flags about adverse events there, which when you drop back a few yards and think about it, that should let the American people realize that we take safety very, very seriously. And if vaccine hesitancy, which is based in part at least on a concern about safety, I think what happened, even though you don't like to see a pause because it gets people wondering what's going on, the fact is it's proved that we take it very, very seriously and should underscore the fact that we're dealing with very safe vaccines.
You know, one of the things that's been challenging and also exciting about the pandemic is the scientific apparatus has also been on full display. So the processes of developing vaccines through various clinical trial phases, of the regulatory process and the safety oversight that Tony's describing. It's been an incredible learning opportunity for the general public to begin to understand how vaccines are not only conceived and developed and studied, but what is the way that we make decisions about whether they're ready for public use and how we monitor them over time. So I think what I would hope is that we find a way to continue to package that new knowledge so that people have comfort in understanding beyond the COVID vaccine and really know what are the ways that they can track and understand the safety and efficacy and then the effectiveness of these vaccines in the field. So applause to everyone who has to be on the public stage, trying to help the public navigate these things also, because it can seem concerning when you see it in the headline, but just as Tony and Mary described, it's a part of the process and it should give everybody comfort that the apparatus behind the scenes usually, but now is out in the public domain, is doing its important work to make sure that vaccines continue to be safe and effective for people, and not just COVID, but other vaccines as well.
While we're on the subject here of the vaccine rollout and tools that might get people to take them, I want to tee up a question from Sarah Fortune, the chair of the Department of Immunology and Infectious Diseases at the Harvard Chan School.
Tony, I was wondering if there have been any surprises in the vaccine rollout and what your thoughts are about the role of vaccine mandates in improving vaccination coverage.
Yeah, you know, the idea of vaccine mandates at the federal level will almost certainly not happen. But I think what we are going to see inevitably, that there are going to be individual organizations that will require vaccines if one wants to participate. That could be, we're already seeing it in certain colleges, which have said, if you want to come to college, you've got to get vaccinated. We will likely see it in certain industries where people will say, if you want to work here, you've got to be vaccinated. So I don't think there's going to be any question that there will be vaccine mandates, but it will not be at the federal level. With regard to surprises, you know, it wasn't a surprise. It was really very gratifying when President Biden took office, how quickly, as soon as, you know, we walked into the office, we all of a sudden had a major full court press on the implementation of vaccine distribution. It was really quite extraordinary. Everything went up very, very quickly. Vaccine community centers, federally qualified health centers, all those things went up. It wasn't a surprise, but it was very gratifying to see.
I just realized I've been talking about the whole population, and of course children are not yet being vaccinated. So I'm really talking about everybody for whom the vaccine's been proven safe and effective. Sorry.
Well, I think we are close to our time. I want to pose one last question to each of you. Does the pandemic end, define that however you want, in 2021? Dr. Fauci, let's start with you.
I believe we will approach a very strong degree of normality by the time we get to the end of the year. It will not end. When you use the word pandemic, Sam, which is a global connotation, it will not end globally this year for sure. And I think that's because of what we've been talking about the inequities of the availability of vaccines to be able to end it. We'll have developed nations like ourselves, the European Union countries, Canada, Australia, et cetera, will have an approach towards, but not complete arrival at normality. But there will always be the threat that you will get variants from those areas of the world in which there are still viral dynamic. So it's not a quick, simple answer to your question because we live in a large, complicated planet that has a lot of inequities.
I'll just go next and just say to Dr. Fauci's point, this is a global issue. And until we can reach all parts of the globe, it will never truly end because we're all interconnected. I will say, though, that it is an opportunity for us to continue to think about collectively how we move forward, empower communities, empower individuals, and really make this issue of public health really public and out of the silos of our journals and textbooks and into people's hearts and minds and dinner tables. So I think it may not end, but it's an opportunity for the continued advancement of science, particularly in people's hearts and minds.
Mary? Sorry.
Well, Garth, you've said that so beautifully. I don't think that we'll be at the end by the end of this year. I'm not even sure how things will, this is a highly communicable virus in a very unequal world in which we're not likely to see vaccine access in some continents like Africa, possibly till 2024. And as Garth just said, we're all connected. This virus went from a corner of China that many of us had never heard of, even though it was a huge city, to virtually every country in just a few months. So we really are all in this together.
All right,
so
Michael, I cut you off. Go ahead.
All of us, yeah.
I feel that we have to be very, very careful, even in the States, in the US, where we're getting a lot of vaccines rolled out, to really push that narrative that it's ending. The most basic understanding of immunology in the elderly is that elderly individuals who are the very people we have gone through, economic shutdowns to protect, generally don't hold on to their immunological protection as well as younger individuals. And I think we have to be extraordinarily cognizant that there is a good chance, especially with young people not being vaccinated, new variants, that we will continue to see surges. I would be very surprised if we don't see resurgence of cases in a much smaller degree this fall and winter. And those will necessarily end up getting into some of the senior living centers and nursing homes. And we'll see additional cases that are very worrying. And I think it's important for us today to start talking about and getting society conditioned that that is a real likelihood so that we don't have an outcry when fall and winter come, but we instead prepare for it beforehand. If it doesn't happen, great, but it's very likely that it might to a certain extent. And I think we'd be very much fooling ourselves in the US even if we start talking about it ending this year.
Karen, you agree? End is a premature word?
End is a premature word, though, certainly in some geographies, people will start to move to some more normalcy. The adage, of course, that no one's safe till everyone is safe will hold true for this pandemic. I do hope that the other adage that we have in medicine, which is it's a teachable moment, that we all take this as a society about the importance of globalism, the importance of inclusion, the importance of equity, the importance of respecting and recognizing science as the foundation for decisions that we make, and of course, the importance of supporting the public health infrastructure so they are more prepared for the next round.
Okay. Well, I believe that is our time. Thank you all. I'd like to thank Dean Williams for having me. Thank you, Dr. Fauci, for your time. Thank you also to Drs. Graham, DeSalvo, Bassett, and Mina for joining us and sharing your expertise today. Thanks very much to the Harvard T.H. Chan School of Public Health and to Google for this excellent conversation. Please join the Harvard T.H. Chan School Signature Series of events as it continues next week. Thursday, May 6th, for Adolescent Mental Health in the Time of COVID. That'll be hosted by Juju Chang, the co-anchor of ABC News' Nightline. Thank you so much for having me, and I hope everyone has a great day.
Bye.
Bye, everybody.
Mm-hmm.